In this next case study, we're going to look at a patient that has a slightly different diagnosis. The last one, primary snoring. This one, mild obstructive sleep apnea. You're going to see some similarities. The report format is going to look the same, but you're going to see a lot of different details, specifically with the graphic analysis. That's what we're going to hone in on, but let's dive into it. Let's go through it section by section. We'll do it a little bit quicker this time since it's review from the last video, but let's go through it and see what this patient has to talk to us about. As a reminder, this is an actual study performed by a patient, but all of their personal information has been redacted for HIPAA compliance. So as we scroll down, we can see that this patient also was referred to evaluate sleep disordered breathing. The same test was done, so the procedure looks identical. Where we start to see some differences is here in the observation section. So we can see that their oxyhemoglobin saturation is 92%, but their minimum desaturation with sleep disordered breathing events was 72%. That's pretty significant given the fact that unless you know how to control your heart rate, you can't deliberately drop your oxygen saturation more than 4% without passing out. So a desaturation of 20% from baseline is pretty substantial, and that's noteworthy. If you look on the scale, this would actually be considered a severe minimum desaturation because it falls in the less than 80% criteria, as noted below. If we look at the apnea-hypopnea index, we clearly see that the patient has 11.6 events per hour. That makes them mild based on those numbers. We look at the respiratory disturbance index of 13.8 events per hour and also see that that fits the mild category based on the criteria. So it's no surprise when we see in the diagnosis section that the physician diagnosed the patient with mild obstructive sleep apnea. Their numbers match. Things make sense so far. Under the recommendations, we see a slight difference from the last test, where this is a recommendation for a consultation to evaluate the use of oral appliance therapy for the treatment of obstructive sleep apnea, not primary snoring. So it makes sense that the diagnosis matches the recommendation for treatment, and this is the primary recommendation from the sleep physician. The alternative treatment recommendations are attended polysomnogram for the purpose of a CPAP titration or an auto-PAP device trial, or we see a consultation with an ear, nose, and throat specialist to evaluate their surgical candidacy. General recommendations, as we can see, are going to remain the same for all patients. Again, at the bottom of the report, this should be signed by a diplomat in sleep medicine or a board-certified sleep specialist. If we continue on to page 2, again, we look at the recording data. How long was the patient wearing their sleep test? We can see that this is 6 hours and 34 minutes. The duration of evaluation, remember that's the good quality recording time, is 6 hours and 22 minutes. A difference of 12 minutes. This is a pretty solid test done by this patient. On the AHI bar, we can see that the result is 12, which is rounded up from 11.6. If we scroll down and look at the analysis, we see their flow evaluation period was 6 hours and 22 minutes. That's where the cannula was in their nose. The SpO2 evaluation period, 6 hours, 23 minutes. That's the pulse ox on their finger. So we see the AHI and RDI match our prior page, and these are the associated events with those indexes. Moving on to page 2, as I mentioned, the graphical analysis is going to get a little more interesting here. We're looking at the obstructive apneas here in the pink. These pink lines represent each obstructive apnea event. Mixed apnea is light purple. Hypopneas are teal, and we can see a cluster of events here in the beginning, another cluster here towards the middle of the test, another cluster here, and another here towards the end. The interesting thing that is going to be common as you start looking at more reports is these hypopnea events directly mirror their oxygen desaturation. This is because a hypopnea is defined as a 30% reduction in airflow followed by a 4% oxygen desaturation. So every time a patient has an airway event followed by an oxygen desaturation of at least 4% or more, it will be defined as a hypopnea, unless the patient has completely collapsed their airway in which case it would be an obstructive apnea identified by the pink lines here. We can also see from the snoring analysis that there was orange almost the entire way through the night. So as you look at this, each one of these episodes, a single snoring episode, is a single hash mark. And you can see we have hundreds, if not thousands, of hash marks throughout the night. So to say that this patient is snoring pretty frequently is accurate. If we scroll down to the bottom section, we see the pulse oximetry, so the pulse and beats per minute here. We also see the oxygen desaturations. This is where it gets pretty interesting. So we always want to make sure that, in general, our patients are in good heart health. One of the effects of apnea is putting increased pressure on the heart. That's why there are so many cardiac diseases related to obstructive sleep apnea. So we can see that this patient's pulse rate is pretty erratic here throughout the night. So the increase and the decrease and the increase and the decrease, this would indicate that the patient is enduring stress throughout the night as they sleep. That makes complete sense because if you look at their blue line in the oxygen desaturation, we can see all of the dips below this dotted line, which represents 90%. There are a significant amount of oxygen drops. One unique fact, if this patient were in a sleep center in a hospital, they would be monitored by a technician. However, if they were in a hospital without being in a sleep study, the nurse would have put oxygen on this patient because they dropped below 90%. So the only reason this patient did not wake up with oxygen on their face is because of where they slept, not how they slept. So when we're looking at this type of pressure put on not only the patient's heart, but on their oxygen saturation, we can see that this is a big problem. As we zoom out here on this last page, remember that this sleep study report is time-stamped from left to right. So this is the beginning of the test all the way through to the end of the test. So if we're looking for correlation, if we see these hypopnea events and desaturations and snoring up here, we scroll down and look at their heart rate, which is erratic here, and then down further and look at their oxygen desaturation here, it makes sense that the reason why their sleep is being disturbed is due to their airway disturbances. So because we see this correlation, and due to the physician's diagnosis of mild obstructive sleep apnea, we can deduce and communicate to the patient that their airway is causing a significant disruption in their sleep pattern. As you can see, there's quite a bit of information we just covered. Many of the fields and the things that we're looking at are similar to the last study, but the data that we got on this patient was significantly different. It's pretty clear that this patient is suffering from obstructive sleep apnea, which is waking them up at night, but it's also causing increased heart and oxygen strain on their body. We would call that oxidative stress. That's where intermittent hypoxemia, low oxygen rate intermittently throughout the night, is causing increased cardiac stress on the body. This is not good for the patient's overall health and specifically their heart health. Conditions like hypertension, drug-resistant hypertension, congestive heart failure, atrial fibrillation, these are all cardiac diseases that are directly related to obstructive sleep apnea. So we can't take this lightly. When we see something like this in a sleep test, we need to be able to articulate it clearly to the patient. So I'm going to pause for a minute. Instead of talking to you, I want to transition into an example of how we would recommend you speak to your patient. So we're going to do a little bit of role play here. Maybe it's funny. You can laugh at me if you want to, but we're going to have some fun. Let's talk back and forth. Okay? So let's pretend that you're Pam and I'm Dr. Mike. And I'm going to have a conversation with you about your sleep study. Now, Pam, just to give a little bit of backstory, you came in because you were having a cleaning done in my office. And you didn't talk to us about airway. We talked to you. But in that screening conversation, our hygienist uncovered that you wake up almost every day with a headache. That headache is right here in your forehead. It kind of feels like a bomb went off. It takes about 15 or 20 minutes once you're awake to go away. And in addition to that headache, you always feel forgetful. So you're constantly forgetting things at home, your keys, your phone, your kids, something like that. And lastly, we see that you have bruxism. We know as dental professionals that bruxism has a very high incidence rate with obstructive sleep apnea. We also know that those morning headaches right here in the front of your forehead are often associated with oxygen stress on your body. So I'm going to talk to you as though you, Pam, are the patient that's had morning headaches, that is forgetful and frustrated with that, and we see that you've got bruxism. All right, let's do it. Hey, Pam, let's take a seat. I'm so glad that we did this test because I think we've uncovered some things that I'd like to talk to you about. So I want to go over your report here from the sleep study that you took home. Now, I want to remind you, we had this sleep study read by a board-certified sleep doctor. So I'm not a physician or a sleep specialist, so I can't diagnose anything that's going on in your sleep. That's why we have a specialist looking at this test and making sure that they're looking at all of the things that they would be seeing, and they just communicate it to us. So I want to go over their report with you. So as we can see in the observation section, it looks like your oxygen level is on par and you're at 92%. We'd like to see that a little bit higher, but anything above 90, we're doing pretty good. We also do see that your oxygen drops to 72%, which is somewhat concerning. We'll go ahead and look at that in a second. We always want to have the oxygen above 90 if at all possible. So what you can see here is the sleep physician actually did diagnose you with mild obstructive sleep apnea. What that means is you've got an index, what they call an apnea-hypopnea index of 11 events per hour. Now, let me kind of explain what that means. When we have apnea events in our body, our airway collapses enough where our oxygen is dropping, it's putting stress on our heart, and our body doesn't like that. And we want to stay asleep, but we have to wake up in order to start breathing again. So each one of those events where your airway collapses and then your brain has to wake up out of its sleep state to open your airway, that's one apneic cycle. So what we saw from your sleep study is that you've got about 11 of those per hour. I know that sounds crazy, waking up 11 times per hour, but it's different than getting up and going to the bathroom. It's really where your brain is just waking up out of the sleep state and becoming more active to reactivate those muscles. That's what's going on. So if we look at the second page on your report, this is where I wanted to kind of show you what's going on. Each one of these light pink lines is where your airway collapsed completely, but the light blue lines is where it partially collapsed and your oxygen was dropping. Each one of these hash marks represents one time that your brain had to wake up to open up the airway and do that whole thing over again. I'm really glad that you did this test because it identified what's disturbing your sleep throughout the night. And frankly, with it being mild, there's a lot of options for you to fix it. So I'm excited that we found out what's making you tired and likely what's causing your headaches. But I do want to point out something that's a little bit more serious. You see the red line here? This is your heart rate throughout the night. And your heart rate is supposed to be steady and consistent, and it's also supposed to drop and be in a more restful spot throughout the night. We can see that your heart rate's going up and down quite a bit, and it actually hit 104 beats per minute. When we look at that, I don't want you to be alarmed here, but when we look at that, we're actually seeing that you're under cardiac stress at night. When we go to sleep, our bodies are supposed to be healing and restoring, and we want our heart to be in a low heart rate and consistent and restful throughout the night. But we see some pretty significant increases in your heart rate. The reason why that's happening is this blue line here. If you look at that, that's where your oxygen's dropping throughout the night. Now, we want your blue line to always be above 90%. That's the dotted line that goes across right there. If that's above 90%, we're okay. But when it starts dipping below 90%, that's where we get concerned. So in a hospital setting, like if you've ever had a friend or a family member in the hospital, I know I have, and sometimes you walk in and they're on oxygen, that's because their oxygen rate in the hospital dropped below 90%. That's why we have the threshold of wanting it always to be above 90. So you can see here that there's quite a few times throughout the night that your oxygen's dropping below 90%, even sometimes pretty significantly down to 72. That was the lowest. So even though that looks pretty bad, the great news is if you correct the apnea, your heart rate will calm down and your oxygen rate will lift up by correcting that. Because if you look at these events where you see this big drop in the blue line and the increase in your heart rate in the red line, if you track that all the way up here, you can see that the hypopneas, the airway events, are what's causing this throughout the night. So I understand that the teeth grinding and the morning headaches were really what brought you in, but I just wanted to share this with you. This is pretty important. And frankly, Pam, I'm glad that we did this test now because apnea gets worse over time. So if we catch it now and you do something about it now, it's going to be a significant improvement to your health. It will improve those headaches that you're waking up with and put you really back on the right track. So let me talk to you about the treatment options and what things we can do for you or where we could refer you. All right, guys. I know that was really long role play, especially because you were quiet and I'm just talking to you. But can you see the dynamic with going through the data on a sleep report? And from a patient perspective, they're more connected to those graphs and those colors as you explain them than they are to the numbers. So if you just sat Pam down and said, you're mild apneic and your number's 11 and this is what you need to do, you're probably not going to connect great with Pam. But if we can connect in that conversation to Pam as a person and the pain points, remember, morning headaches, forgetfulness, and her bruxism, if we can connect to those pain points and point her in the right direction based on this information, we've got a really solid chance that Pam is going to understand as a patient that she needs to move forward with something. Now, this is not to just talk her into your treatment of choice. We'll talk about the treatment options here in a few minutes. But the main purpose here is connecting with your patient and clearly explaining their test results in a way that they can take a step forward and move to action. That's the goal. Let's talk about the next patient in just a second.